Hi, I'm Dr. Jeffrey Antimarino. I'm a board-certified plastic surgeon at Bellissimo Plastic Surgery and Medispa. Tonight is a special night for us. We are fast approaching October, which, as you may well know, it's National Breast Cancer Awareness Month. So we're going to start off things a little bit earlier, and we're going to dedicate this episode of our Facebook Live to breast reconstruction. And we'd help you, hopefully you would kind of type in some questions, join us, make some comments, because this is a really important topic. We all know about breast cancer, but a lot of women out there that are developing breast cancer and going through surgery or chemotherapy and other trials and tribulations may not be aware of all of the options they have for breast reconstruction. So as a group, as Bellissimo Plastic Surgery, we're really trying to get the word out and educate women that they have options for breast reconstructions if they choose to go through it. So with that, I'm going to turn over the questions over to Ella, and let's get started for tonight.
Hi. To begin with, what exactly is breast reconstruction surgery?
Breast reconstruction is a little bit different than other types of breast surgery. When you think about breast surgery, you think about four different things. Number one, as we all know, breast augmentation, so we're making breast bigger. Breast lifts, breast reductions, and then breast reconstruction. The first three is really you're using the woman's breast tissue, the tissue she already has. So we're either going to make it augmented, make it a little bit bigger with an implant, or we're going to lift it or reshape it, remold it, or even make it a little bit smaller. So we're working with her tissue. With a breast reconstruction, this is really challenging because all of the breast tissue has been removed to get rid of the cancer. So really we have what's left over is the skin envelope of the breast and the chest wall, but nothing to work with. So we really have to build a breast out of nothing.
Are there different types of breast reconstruction surgeries?
Breast reconstruction is really two main processes, or two main types, and then there's some other ways of doing it within each category, so to speak. But the broad categories are an implant-based surgery, which is the implants that you see here. Most of us would use a silicone-based implant more than a saline. The other side of the categories is what we call an autologous tissue. So we use the woman's own tissue to build a breast. Classically, that's usually come from the stomach or the abdominal wall, and so we build a breast out of the skin and the fatty tissue from the abdominal wall. You can use the muscle from the back and bring that around. There's other areas of the body, sometimes with part of the thigh or part of the buttock, that you can use a woman's own tissue to build. And so they're completely different, but depending upon what the woman wants or is best for her, we can go one way or the other. Now, in my 16 years of being in private practice and the years that I spent in training, breast reconstruction has taken off, and it's really erupted with some really terrific techniques. We've refined it. Women are getting back to work in their activities much faster now. So even at the university levels where we used to do a lot more autologous tissue reconstruction, breast implant and tissue expanders have become the foremost way of building a breast. With the nuances and the improvements in the tissue expanders, the implants, and using other tissues such as something called alloderm that your breast surgeon, plastic surgeon can discuss more. That technique has really given a really nice aesthetic result. It's a much faster return to work and activities. It fits a lot of women, especially women now, because we're seeing breast cancer really shift to a younger crowd. The majority of my ladies in the practice are somewhere between 35 and late 40s. So it used to be ladies in their late 50s were young women, and we were seeing it more in the 60s and 70s. So these younger ladies are active, they have jobs, they have young kids at home. So sometimes with the autologous tissue, there's more time spent in the hospital and more downtime. It's a terrific way to build a breast, but a lot of ladies can't afford that downtime. So the advent of this new way of doing it, tissue expander and implant-based surgery, has really helped a lot of those women. So they can go either way, so there's more choices for every woman if they so desire to have a reconstruction.
The next question is kind of twofold. Is this done before chemotherapy, and do you work with the oncologist? Do you work alongside them? Is it something you have a conversation with the patient?
It's a good question. So breast cancer and breast reconstruction is a team approach, and there's a breast surgeon, there's usually a general surgeon. If they want to do breast reconstruction, obviously there's a plastic surgeon, and then there's an oncologist, usually a medical oncologist, and a radiation oncologist if the lady needs radiation therapy. So there's a team of at least 4 doctors and probably the primary care doctor as well. So it's a whole team of us, and we should all be talking. We should all be on the same position to help this lady get through the process. So to answer your question, most of the time the breast reconstruction starts before chemotherapy and certainly before radiation therapy. And we'll kind of get in, I think in a few minutes we'll start talking about the timing of breast reconstruction, but usually it's done prior to chemo and radiation, at least the first stage of that, and we're going to go through that.
Does it interfere with the treatment?
Yeah, it does not interfere with treatment at all, and so I think that was one of the biggest, I want to say a myth, but it was a biggest misconception, is that the plastic surgeon and the reconstruction would interfere with a woman's ability to go through the surgery to remove the breast or the radiation or chemotherapy. But I'm just going to tell you, breast reconstruction in no way, shape, or form will interfere with a woman's ability to go through the treatment to get rid of breast cancer. So what I try to tell ladies is that the breast surgeon and the oncologist are really there to extend your life, to get rid of the cancer and do the things that are necessary that cancer never comes back. The plastic surgeon is icing on the cake. What we try to do is give quality of life. We want to restore a woman's self-confidence. We want to restore her sense of femininity. We want to restore her female shape. So we work as a team. We have the physical side and we have more of the psychological, spiritual side. And we should all work together to do that. But it does not interfere with any form of the oncology process.
Would you recommend breast reconstruction for breast cancer survivors?
I would recommend every woman who has been diagnosed with breast cancer to at least have a conversation with a plastic surgeon. Multiple studies have shown, and I can tell you personal experience with patients in my practice, the psychological benefits of undergoing a breast reconstruction are enormous. That sense of femininity, that sense of being restored both physically and mentally is paramount. So breast reconstruction may not be for every woman. It might be the timing isn't right either. So you should at least know what your options are, and you should at least have that information so that you make the best decision for you. And I'll just segue into the timing of reconstruction. There is immediate and delayed breast reconstruction. The immediate reconstruction means that as the general surgeon goes in to do the mastectomy, the plastic surgeon would go in either in conjunction or immediately after him at the same operation, and the breast reconstruction, at least the first stage, will be started at that point. For most of the stuff that I do is putting in a tissue expander under the muscle because there's some of the skin that's been removed. The tissue expander now acts as a balloon and helps stretch out that skin and make a pocket that later on we would put in a silicone breast implant and make that breast tissue or that breast mount. At that time, the woman goes to sleep. She's complete. She has both breasts. When she wakes up after surgery, she would have her natural breast and at least a breast mount on the other side. Psychologically, that is really important. Many women are now opting to have both breasts removed, even though they only have breast cancer on one side. Again, she goes to sleep with both breasts. She wakes up with 2 breast mounts. The way that this works and the way we do the surgery, many women, once they come out of surgery, are actually wearing the same clothes and the same bras they were going into surgery. I can't tell you the impact that has on their mental fortitude and just from just feeling whole. That all gets done at that time, and then as the patient heals, then she can undergo chemotherapy and radiation. Now, the delayed means that the lady undergoes a mastectomy, It's sewn up, she has nothing there, she can wear a prosthesis as that heals, and at some time in the future, whether that's 6 months, 6 years, or 60 years, she can come back to a plastic surgeon and say, you know, I really like to have a breast reconstruction. And then he can sit down, or she can sit down with that patient and go through her options. The problem is she doesn't have as many options in a delayed setting as she would have with an immediate reconstruction. So the options are much better in immediate, and the psychological benefits are much better in an immediate reconstruction. But again, it's up to the lady, and I've had some ladies come in and say, I'm just so overwhelmed with breast cancer, I just want to get it out. I don't want to think about a reconstruction at that time, and that's okay. As a plastic surgery society, we will support that woman and any woman, whether they undergo reconstruction or not. We're just here to help.
Will the reconstructed breast match the remaining breast?
A couple of good things about that. As many years ago, breast reconstruction was only for the breast that had breast cancer. The normal side was not covered by insurance. Now, both sides are covered by insurance, and that was a federal mandate. That was a great advancement in breast reconstruction. So if a lady opts to have a mastectomy on one side and keep her breast on the other, the goal is always symmetry. So the first stage of the operation would be to either somehow make a breast mount, either with a tissue expander and implant as one way, or as I talked about, autologous, or using her own tissue. You allow that to heal. You don't do anything to that the normal breast until the second stage. The second stage operation is typically, for me, removing the tissue expander and putting in an implant, and then doing the surgery on the other side to make them symmetrical. That may be a simple augmentation, just putting in an implant. It could be a breast lift. It could be a breast reduction. It could be a combination of a breast lift and an augmentation. So whatever needs to be done for symmetry, we would do that at the second stage. The amazing thing now is that with advances, as I said before, some women are candidates to actually go a one-staged operation. So you may not even need a tissue expander. Some women can actually just undergo, at the time of the mastectomy, putting in an implant and doing the surgery on the other side at the same time. When she wakes up, it's completely done. That's not widespread for every woman, but you may be a candidate to have it done that way.
I just want to reiterate, does insurance cover reconstruction for both breasts then?
It does. So it doesn't even depend on the policy, but we still have to get it approved, but it will cover not only the affected breast, but the opposite breast, and it covers it ongoingly. So as I said before, sometimes there's the first stage to build the breast mound, the second stage to either take out the expander, put in an implant, or to revise the mound a little bit and then work on the second breast. That would be the second stage. And then, as we'll get into in a little bit, a nipple reconstruction might be a third small operation. So there might be stages along the way, and all of them are covered as you go forward.
You just segued into my next question. What is done to restore the nipples or areola?
Different ways of doing that. My preferred way is to actually use the skin on the breast and make the nipple and the areola. Some surgeons use that tissue to make the nipple. Others use skin graft from the groin area, and they can use that tissue to make a nipple and the areola. So that can be done. It's a pretty quick surgery. There's ups and downs to that, and that's something I always talk to my patients about later on. But for most women, that's a possible surgery later on to fulfill or to complete the process.
Sounds like a very personal decision for the patient.
It is. It's a long process, and so the plastic surgeon is so paramount to that, because as the woman progresses through, the one person that doesn't change is your plastic surgeon if you have the reconstruction. The general surgeon that does the mastectomy or the lumpectomy, they'll follow you for a while, and then they're not needed any longer. Once chemotherapy is done, the medical oncologist doesn't really go away completely, but it starts to take a back seat. The radiation oncologist is the same thing, but the plastic surgeon is ongoing through all of those processes. I see patients afterwards at least year to year. Most women follow up with their oncologist at least year to year, the medical oncologist. So there's the team, but there are the plastic surgeon is always involved throughout every part of that reconstructive and post-op process.
Will the reconstructed breast have sensation to it?
Generally, no. Classically, when you do a mastectomy, you remove the nipple and the areola along with a small segment of skin. There are ways, and some women can do a nipple sparing. Sometimes you just take the nipple and do a skin sparing. But generally speaking, the nerve that supplies sensation to the nipple area is removed with the breast tissue. So most of the time, it's the breast is not completely numb, but somewhat numb.
Who is the best candidate for breast reconstruction surgery?
Any lady that is otherwise in good health. I mean, that's paramount. Secondly, a lady that is probably within 20 to 30 pounds from her ideal body weight. Certainly one who's not smoking. Somebody who is fit and at least exercises some will do better than other ladies. But definitely the biggest things are in good health and non-smoking, and somewhere within a range of your ideal body weight.
Is the consultation done prior to the treatment? Is it something they meet with you or as a team with the surgeon?
They meet. It's an important part of the process. Yes, they would meet with me. You brought up a nice thing. It would be great to have a conversation with everybody. All the doctors in the room. It's very hard to do that. But many hospitals and many groups are getting the general surgeon and the plastic surgeons together and actually training them together in seminars so that the way to treat each woman is individualized. So where you might do a classic mastectomy scar on one lady, you might do a skin sparing on another. And the plastic surgeon and general surgery actually plan out the operation together to give the lady the best outcome. But that being said, it's the education of the consultation is very important. So when ladies come to me, I allow at least an hour to an hour and a half because we need to talk about tissue expanders and implants and talk about autologous so that the lady we can really go into detail about what that entails, what their post-op course is going to be like, when they can get back to work, when they can get back to exercise. When does the chemotherapy start? When does the radiation start? How that affects it. So it's all timed so that we work in orchestrated fashion. So that consultation is extremely important. I like it when the lady brings in family with her, husband, children, friends, anybody, because at that point the lady's so overwhelmed with the diagnosis of breast cancer and then I start talking about, or a plastic surgeon start talking about a lot of the reconstruction. This is what we can do after examining you. These are your options. It can be overwhelming. So it's really nice to have that, at least one other person there taking notes, asking questions, because it's something that they're going to have to mull over and let sink in. And a lot of times I touch base with them later. We talk on the phone, or I bring them back in and we retouch some of the topics that we've gone through, go through any other questions. So it's a very important process, but it should be the same process as you do with your general surgeon for to discuss whether you're going to have a mastectomy or a lumpectomy. The oncologist, what kind of chemo, how long do you need radiation, what's that like? But these are all questions that you need to have answers to, and you deserve to have the answers to those. So feel free to ask questions to all of your doctors.
How do I prepare for breast reconstruction surgery?
That's a hard question because it's not like other surgeries where you think about doing a breast reduction, or you think about doing a breast augmentation or a breast lift, and you can plan and you can think, okay, this might be the best time. Breast cancer hits at any time, day or night, weekends and holidays, it doesn't really matter. So once you get that diagnosis, I like to get ladies, once they get the diagnosis, is to get the team together, everybody present their plan to her and her family, let them decide what to do, and then get her into the operating room so that for her mental well-being, it's done. Before it really sinks in that she has cancer, it's all done. my part's done, or at least in the big part is done, and then we get her on to the oncological stage so that she knows that she's taking care of what was kind of attacking her body. So you can't really plan to be in the best of shape or anything else. You just have to deal with it. So I guess to be prepared is if you do have that diagnosis, be prepared to be aggressive and go after it. The other thing I would encourage women is yearly or every other year mammograms are really and extremely important. Don't walk away from those. Self-exams are also very important. I think there was a push there for a while that they were, a lot of negative findings on that. But you know what? A lot of my patients come in and said they found the lump examining themselves. And some ladies just do it monthly, and I think it's really something that you need to do.
So let me ask, if I have reconstruction, would I continue getting a mammogram if I have implants? Do you have to go back?
No, you would have a mammogram on the normal side. So if you plan on doing just the cancer, the side that has the cancer, you would need mammograms on the other side. You would still need to be checked because you can still have local recurrences of breast cancer even in a reconstructed breast. So those are mostly checks with the skin. Sometimes they'll do PET scans and MRIs. So that's why the oncologist is always key to ongoing examinations.
I want to touch on post-treatment care, and Sherry asked, what would the downtime be?
Depending upon the type of reconstruction you choose. So let's get into that just a little bit. So say you opt to do an immediate breast reconstruction, and I show up with the general surgeon, we do a mastectomy, and I put in a tissue expander. You would stay, usually it's one night in the hospital, you're home the next day. I see you a few days after surgery, and then I follow you week to week. Generally speaking, at about 3 weeks after surgery, I'll start filling this more. I fill it some with saline in the operating room, and then I can fill whatever else I need to in the office. I get you back to exercising in about 3 weeks. Some women can go back to work in a couple of weeks. So you get back to things pretty quick. If you undergo the autologous or your own tissue, then that takes a little bit more time. It's a longer time in the operating room. This putting in a tissue expander takes me about an hour per side with, again, the one night stay. The autologous can take sometimes 3 or 4 hours or longer. Most women are in the hospital anywhere from 4 to 5 days. It can be several weeks off of work and even up to about 6 weeks off of work. So it's a little bit more downtime for that surgery. It's a terrific way to build a breast. So don't take it that everybody needs to undergo implant surgery. Autologous tissue is an excellent way of doing a breast reconstruction. It just is more involved right up at the front, and some women just don't have that much time to give.
Are there any risks with reconstruction?
Well, like anything, there's always risks, and so the surgeons work together to minimize risks. Small risks are bleeding and infection. Bleeding risks are less than 1%. Infection risks, again, are maybe 1%. There is a risk in an implant that the incision would open up and expose the implant, especially if a woman is undergoing radiation in the future. Most of the time, that is well healed by the time the radiation starts. The reconstructive complications are higher in a delayed reconstruction, especially if there's been a radiation on that side. So that's why I'm more inclined to do an immediate reconstruction, because there's actually less complications with that. If you're using your own tissue, the reconstructive complications with that are sometimes the incisions don't heal well. Sometimes the tissue that you move up, because it needs a blood supply, sometimes it's not getting enough blood supply, so sometimes that tissue can get calcified and not survive, and so you have to come back later and sort of trim that off. So it's a good question, but it's hard to really go into great detail with that. It's something that I would probably do more at the time of the consultation.
So in your post-treatment, are they sent home with a support garment, or what would they be sent home? Is there
if I use a tissue expander, then they're sent home really with a post-operative bra and some drains. So drains are little rubber tubes to suction balls. They usually keep those in sometimes a week, maybe 2 weeks at the most. So that would be the only garments they would need.
How soon can a patient exercise after surgery?
In a tissue expander, I usually have them exercising within about 3 weeks. That's non-impact, so no running, jumping, or jogging, but she can go back to Stairmaster, elliptical, walking, some weight lifting, abdominal toning. With the autologous tissue, it would be more downtime, so it would probably be 3 weeks before you can start walking and doing some light stuff, but it would probably be more like 6 to 8 weeks.
What about driving? How soon can a patient drive?
Again, depending upon expander and implant-based surgery versus autologous. Most of my ladies I have somebody drive them for their first visit, which is about 4 days after surgery. The second week that I see her, so usually that's a week later, and about 11 to 12 days later, if she feels comfortable to drive, she can drive at that time. With the autologous tissue, it might be several weeks before she feels comfortable to drive.
Do people combine procedures with breast reconstruction?
I guess you could. Typically, we don't. Typically, it's enough involved to build the breast mound, and then also to do the surgery on the other breast for symmetry. So that's usually enough at that time.
Does the surgery last forever? Is there maintenance involved?
Well, depending upon the age that you have the reconstruction, as you get older, things may change. If you use an implant, at some point you're probably going to have to replace that implant. The silicone gel implants, generally speaking, would last somewhere in the vicinity of about 20 years, and then they would probably need to be replaced. Flat-based surgery may need some touch-ups later on as well. So most of the time they'll last several years before, once you get the mound the way you want it and the reconstruction the way you want it, most of the time that lasts several years before you need some minor surgery to touch it up or to swap out the implant. I've seen ladies just recently that have had reconstruction 5-10 years ago. Their bodies have changed just because they've gotten older, other things have gone on. So you can do little, half an hour procedures, 45-minute procedures as an outpatient basis to tighten it up a little.
Danielle asks, is reconstruction done before or after radiation?
Reconstruction, in the immediate process, I like to get everything done before radiation. That's a great question. Radiation makes the tissue a little bit more fibrous or less pliable. So you'd like to get all of what we want it done in the immediate stage before the radiation hits. And again, we would not hold up radiation to the time we get everything the way we want it. So that's timed out by the plastic surgeon so it won't interfere. But again, if you opt for the delayed reconstruction, some of those women have had radiation, so when they come back in, now the surgeon's dealing with more scarring, breast skin that's not as pliable, doesn't want to move as well. So your options may not be the same in a delayed situation.
What qualifications should someone performing a breast reconstruction surgery have?
Well, you'd want to do your homework. The nice thing about breast reconstruction, it's usually done at a more bigger hospital. The general surgeons are involved, so the plastic surgeon really needs, just like everybody else involved, needs to be board certified in their specialty. This is an area that plastic surgeons are very well trained in. It's also an area that most other specialties that are doing some cosmetic surgery don't get involved in because they don't really have the training to do it. So it is something we've not really had to worry about so much, but you do want to make sure that you have a board certified plastic surgeon as well as a board certified general surgeon, board certified oncologist, and also that they have the experience, that it's a team that's experienced, they're specific for what you need, not just what everybody needs.
You touched on it's at a bigger location. What locations do you offer breast reconstruction?
I do breast reconstruction here locally at UPMC East, also at both of the Excella hospitals in Greensburg, at the Westmoreland Hospital, and also the hospital in Latrobe. The first, if you do the immediate reconstruction, that's always done in a hospital because you would probably spend the night. The second stage or even the third stage, I do those in an outpatient setting, so I do those at surgery centers.
Do you have privileges at Passavant Hospital, Danielle asked?
I do not. The three major hospitals that I have privileges are the ones I mentioned: UPMC East, Westmoreland Hospital in Greensburg, and Latrobe Hospital in Latrobe.
Would you recommend a patient talk with other breast cancer survivors about this surgery?
Absolutely. I think you really need to know what's coming your way. I think it's uplifting. It's always amazing to see women change as they go through this process. Women are so unique because they get stronger as the process goes on. And some of the women that I'm seeing in the first consultation, they're dismayed, they're anxious, they've got the worst diagnosis that they could possibly imagine. They're thinking a lot of things. They're thinking a lot of what can happen if this, what if it can happen to that, what's going to happen to my family, what's going to happen with my kids. So talking to somebody who's been through that process can be so helpful to sort of quiet down those anxieties, put perspective on something that there's no way that you could have perspective on. And it's amazing as those ladies go through, they become that beacon and that strength, of that pillar to go back and help other women kind of come through the process. That's why the breast walks, the campaigns are so important, because you have a chance to talk to women that have gone through it, got to the other side, and have done well. And so there is hope, there is cures, there are people that, ladies that can come through this and do well and get back to their lifestyle.
Why is breast reconstruction for breast cancer survivors specifically important to you?
It's always been part of my practice. It will always be part of my practice. Luckily, I have an aunt that's had a history of breast cancer, but it's really not touched my family that much, and that's a blessing. But as I said before, to be able to be part of a team that can put a lady back together, both physically and psychologically and emotionally, is terrific.
Do you have anything planned special for Breast Cancer Awareness Month?
So,
you've just been informed.
We've just been informed. So, anyway, well, listen, we're happy that everybody tuned in. We have some great things coming up in the month of October, as we try to do it every year. But October 10th, we're going to have a really special live Facebook. We're actually going to have some breast cancer survivors here live talking about their experiences. So again, as you said before, these ladies are willing to tell their story, their ups and downs, trials and tribulations. And again, I would want you and anybody that you know that might be battling cancer or to tune in that time. It's October 10th. I believe we're doing it at 7 o'clock, same time. And so we really want to get the word out. Education is so important. There's so many ladies that I see 5 and 6 years down the line after having a mastectomy that come in and say, I wish I would have known. I would have liked to have done the immediate reconstruction. I don't like the look of that scar on me. Every time I look at the mastectomy scar, it reminds me that I had breast cancer. So that's why the immediate reconstruction and reconstruction for some women is so important. So if you can get somebody involved in a few weeks on October 10th again, tune in, ask us questions, ask these ladies questions, which is more important than asking me questions. It would be really terrific. It would help educate a lot of ladies.
That's all I have for you.
Okay. Well, listen, thank you again. I hope this was informative. Any other questions that you have, you can call us 844-496-6647 or visit us on our website, www.bellissimoplasticsurgery.com. So again, thank you for tuning in, and we'll see you October 10th, 7 o'clock.